This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everyone to another installment in our Pediatric Hospital Medicine podcast series. We're on episode number 14. We're coming to you from Children's Hospital of Pittsburgh of UPMC. My name is Dr. Tony Tarchichi. I'm your host, and as always, I'm a MedPeds trained pediatric hospitalist here at the Children's Hospital of Pittsburgh, Paul C. Gaffney Division of Pediatric Hospital Medicine. I'm going to introduce my guest today. You all remember her from our last episode, Dr. Arcangela Balest, Assistant Professor in the Department of Pediatrics, member of the Division of Neonatology. She was a member of our pediatric hospitalist group for about 4 to 5 years. Prior to that, she was the director at Allegheny General, the Division of Neonatology, then came to us and has now joined our Division of Neonatology. And she was kind enough to give her time again today. So Dr. Balest, welcome and thank you.
Thank you, Tony. I'm happy to be here with you.
So before we get started, I want to do a couple of things. I want to first thank Children's Hospital of Pittsburgh. As you all probably heard in this intro, there's music now, which we've never had before. The Children's Hospital has given us a new studio. Well, not given us. They've created a new studio, and they've been kind enough to allow us to use this studio. I also want to thank Jake, our new video producer, for helping us out with this particular podcast. I also want to say thank you to anybody who has filled out the survey I sent out last time. We are going to do our drawing for our free or our $10 Amazon gift cards on St. Patrick's Day. So thank you again to anybody who's filled out the survey. Your comments are sincerely appreciated. Your thoughts are sincerely appreciated. We will keep it open for a few more days, so please, if you haven't, please fill it out. We're looking to improve in any way we can. So I thank you again. So now, this particular podcast, we're diving into neonatal withdrawal syndrome, ARC. And this, I have to be frank with you, is a bigger topic than I expected it to be. So first, what we're going to do is define neonatal withdrawal syndrome from neonatal abstinence syndrome. I also want to let you all know my seasonal allergies have kicked in this year. I'm afflicted by them every spring. And so this is why I sound like I do. So neonatal withdrawal syndrome is the general term that's used by any drug, whether illicit or prescribed, that a mother is on that a child has an issue with when they're first born. Neonatal abstinence syndrome really focuses specifically on the withdrawal from opiates. When a mother is on opiates when she is pregnant, intrauterine opiate usage, and the child is born and has withdrawal syndrome from it. That's a little hard to tease out in the literature because sometimes it's used interchangeably, but if you read the AAP clinical report from 2012, which we did, it's clearly laid out. All right, so let's start with the beginning in terms of epidemiology. Now, epidemiology for this is interesting because there is a quote that is often referenced from 2009 to 2013. The incidence of neonatal withdrawal syndrome, especially neonatal abstinence syndrome, quintupled in the U.S., increased by 5 times. Now, again, unless you've been, not around at all, you've been hearing about the opiate crisis that we're in terms of many, many more people dying from opiates than ever before. Now, if you look at the epidemiology, there is 3 major articles, but 2 major articles that are referenced in everything, including the clinical report, the recent review by ACOG and AAP and others. And these 2 articles are Neonatal Abstinence Syndrome and Associated Healthcare Expenditures, U.S. 2000-2009. That's in JAMA 2012, issue 307, number 18. The main author of this, Dr. Stephen Patrick, he is an author in every single major epidemiologic survey of neonatal abstinence syndrome. The other authors for that paper are Robert Schumacher, Brian Bennyworth, Elizabeth Kranz, Jennifer McAllister, and Matthew Davis. The second article that is really referenced everywhere is increasing incidence and geographic distribution of neonatal abstinence syndrome, U.S. 2009-2012. That's in the Journal of Perinatology, 2015, in August, issue 35, number 8. Again, Dr. Stephen Patrick is the first author. Matthew Davis, Christopher Lehman, and William Cooper are also authors. The third one we found that Dr. Balest and I liked was increasing incidence of the neonatal abstinence syndrome in the U.S. neonatal ICUs. The first author there is Dr. Withdrawal, then Dr. Stephen Patrick, Monica Bennett, Karna Murthy, John Sousa, P. Brian Smith, Reese Clark, and Alan Spitzer. So again, I'm going to start with my other disclaimer that I say, which is if I mispronounce anyone's name, I apologize. I have butchered names in the past. It's not purposeful. I simply don't know how to pronounce your name. The interesting thing that I learned from these articles, ARC, is a couple. One, the number one drug seemingly used by women or whose children are having withdrawal is methadone. That is the most prevalent. Do you agree?
Yes, although buprenorphine is on the rise in use for withdrawal of women or maintenance therapy of women, of pregnant women during gestation.
And when they talk about these per 1,000 hospital births. So in one statistic from the CDC, from 1999 to 2013, the incidence quadrupled from 1.5 to 6 cases per 1,000 hospital births. And that's the CDC. Then they talk about hospital costs. And this makes total sense. The more ICU time you use, the more expensive it's going to get. But the numbers were a little surprising. Hospital costs for newborns with neonatal abstinence syndrome, and that came from that third article, the New England Journal of Medicine, with Dr. Stephen Patrick. For $66,700 for an infant born with neonatal abstinence syndrome for their hospital stay, compared to only $3,500 for those without neonatal abstinence syndrome. The length of stay is much longer. Without neonatal abstinence syndrome, you're in the hospital about 2.1 days, which makes sense. With the average length of stay with neonatal abstinence syndrome is 16.9 days, which is a huge number.
So those are babies treated for neonatal abstinence. The observation period for infants exposed in utero is a minimum of 5 days. Mm-hmm. So that even a baby who isn't treated has a longer length of stay.
Just in general. All right, so that's that's a brief overview of the epidemiology. In short, that was easy. It's increasing, it's on the rise, you're seeing it, it's more expensive, and anyone who works in a nursery is seeing it. It's afflicting all parts of the country. All right, Art, should we start with, in the past we have done bad dad jokes or corny jokes to kind of break this up a little bit. As we've used up a lot of those that we found online, I'm going to switch to interesting trivia. So, Ark, did you want to go first?
Yeah, so my first bit of trivia actually relates to our topic, so not a cultural interesting bit, but something I found very interesting relating to opiate and opioid use. So heroin was initially marketed by Bayer in 1898 as safe and non-addictive and a substitute for morphine. And it was used to help people appropriately withdraw, or not appropriately. It was supposed to be a medication, but to withdraw from morphine like methadone is now. But the label safe and non-addictive I found fascinating and just wrong.
My trivia is different. It's very Pittsburgh related. Mr. Rogers, if you all remember Mr. Rogers' PBS show, he always mentioned out loud that he was feeding his fish because one time a young blind viewer asked him to do so. She wanted to know if the fish were okay. So then he mentioned it every other show for the rest of the show out loud so that one viewer knew, and if there were any other viewers. All right, let's talk about all of the drugs, potential drugs of abuse or prescription drugs that can cause neonatal drug withdrawal. So, Ark, would you mind starting out with the one that is now legal in a number of states, marijuana?
Yeah, so there is not a defined withdrawal syndrome from cannabis. In fact, we don't really think that there is a withdrawal syndrome like we see with opiate and opioid withdrawal. We don't really know a lot about long-term effects of cannabis, so long-term effects on cognitive development or behavior. There is a questionable effect on fetal growth, but again, that's not well studied either. So commonly used drug, but not something with a withdrawal syndrome associated with it.
Now, one of the things we're going to get into in this segment is really discussing withdrawal versus toxicity. And this next drug is important for that. So the next drug we're going to talk about is cocaine. Now, in cocaine, there is not really an abstinence syndrome after intrauterine exposure to cocaine or amphetamines clearly identified. Is that right, Arc?
Correct. And so we'll see babies after delivery with some neurologic signs, similar to what you might see in an adult using cocaine. So irritability, tremors, different from an adult, a high-pitched cry, increased sucking, but again, not a withdrawal effect, but actually an effect of the drug. And maybe now's a good time to bring up, so people will use the Finnegan scoring system for drugs other than opioids, but it was really developed for opioids, and so it's not validated for that reason. So while we know that other drugs can certainly attenuate the effects or augment the effects of opioids and opioid withdrawal, there's not an isolated withdrawal syndrome, or there's not a withdrawal syndrome associated with isolated use of that drug. But polydrug use in a pregnant mom will affect the withdrawal symptoms that are seen in her baby. And similar to that are SSRIs. So, okay, forget that.
So the other thing with cocaine, let's define this withdrawal versus toxicity effect just in case you're driving and aren't sure. Withdrawal, it makes sense as the drug is leaving your body and it goes away, then your symptoms increase. For toxicity, the exact opposite. As the drug is leaving your body, the symptoms decrease, because with toxicity, the drug is causing the symptoms. With withdrawal, the lack of drug is causing the symptoms. And so that's why it's a little bit different. For cocaine, this is more of a toxicity than a drug. And remember, this would occur most frequently if a baby was going to have with toxicity symptoms of cocaine in a second or third postnatal day, roughly. But cocaine or its metabolites can be detected in the neonatal urine for up to 7 days after delivery. And like Ark said, we don't have a good scoring system for this. The Finnegan scoring system isn't really designed for it. It's used in research literature, but it's really not designed for it at all. And as Ark said, that there was one study done where it is discussed in the AAP clinical report, and let's just define that one. So the AAP clinical report is done in 2012 in Pediatrics, issue number 129. The title is Neonatal Drug Withdrawal. The authors are Mark L. Hudak, Rosemarie Tan, and the Committee on Drugs and the Committee on Fetus and Newborn. In it, they discuss an article where only 6% of babies whose mothers only took cocaine really had toxicity symptoms. In this article, they said 14% of babies whose mothers only took heroin had toxicity symptoms, but 35% of babies whose mothers took both heroin and cocaine had toxicity and withdrawal symptoms. So really, they attenuate each other. Is that a good, fair way to say it?
Yes. So, and not just cocaine. Use of benzodiazepine, anything in addition to the opioid will change the presentation.
And methamphetamines, which is in the cocaine class, roughly, it's an extremely potent sympathomimetic agent, induces euphoria, increases alertness and self-confidence, because it produces this mass efflux of dopamine in the central nervous system. For this drug, it's a little different. These women who take it when they're pregnant are at significantly increased risk for preterm birth, placental abruption, fetal distress, intrauterine growth restriction, which are similar to the rates of cocaine abuse. Really, only 4% of kids exposed to it were treated for any type of toxicity or withdrawal, so you get seemingly less of it. And there are reports of long-term adverse neurotoxic effects from in utero methamphetamine exposure, specifically on behavior, lower cognitive skills, physical dexterity. But so as Ark was alluding to, we should talk about SSRIs because it's similar to cocaine and methamphetamines, only in that you really don't get a withdrawal syndrome. You get, we think, a toxicity syndrome. But just to remind yourself, SSRIs are relatively new. if you're listening to this, I mean, they've been around for about 30 years. They were first came out in 1988. And they're, as of now, most frequently used drug to treat depression in both pregnant and non-pregnant people. And in fact, it's a recommendation that if the pregnant woman is on an SSRI for clinical depression and a significant depression, she should stay on the medication because the risk of significant depression to her and her baby is actually worse. Is that right, Arc?
Yes. So there's no need to stop the SSRIs during pregnancy. And this is one where there actually is some data to support that the findings in a newborn born to a mom who took SSRIs are more related to a toxicity syndrome and not a withdrawal, because levels the baby's symptoms decline as blood levels of the SSRI decrease in the baby, which is what you would see with a toxic effect and not with a withdrawal.
And that was also in our clinical report, the AP clinical report, and they were talking about the 5-HII metabolite cord blood concentrations that Arc was mentioning. So several recent reviews on SSRIs really haven't identified adverse neurodevelopmental outcomes in infants born to women who are treated with SSRIs during pregnancy, but mostly case reports and adverse drug reaction reports and some prospective studies, they link the third trimester use of SSRIs in pregnant women to a constellation of signs that a baby may have when they're born, specifically continuous crying, irritability, jitteriness, restlessness. Now, Arc, before I give you the rest of the list, that seems to be on every list. Continuous crying, irritability, jitteriness is how just about all of these start. Would you agree?
Yes, and well, because if you think about it, most of these are stimulants, right? And the withdrawal effect, and I think you're going to get into it, but what the chemistry is, but it's also a stimulated state, a central nervous system stimulated state. So I'll let you explain that.
And so the other side effects quickly for SSRIs in a neonate born to a mother who's taken up for toxicity: restlessness, shivering, fevers, tremors, hypertonia or rigidity, tachypnea or respiratory distress, feeding difficulty, sleep disturbance, hypoglycemia, and seizures. Oh, one quick thing. So I had a few people on the surveys comment that the references, I read them too quickly, and I do. If you click on the link that I provide to get the CME credit, even if you don't want the CME credit, that link will have all of the references for any of the podcasts I've done. So if you want to use them for teaching purposes or just for your own reading, just click on that link, go to the University of Pittsburgh site, create a quick free login and password, and you can access all of the references I've used to make it easy. The onset of signs of SSRI toxicity from the moment a child's born to when you see them can be several hours to several days and usually resolve within about a week or two. And then infants severely affected, sometimes they recommend a short-term course of chlorpromazine for relief of symptoms. Arc, have you ever had to use that?
No, I have not. And I know that a lot of the articles reference scoring for SSRIs or cocaine use, but we don't do that. So we'll begin scoring if a mom is known to have been on an opioid during her pregnancy. We'll screen for other drugs of abuse just because of the frequent polydrug abuse in people who are on opioids, and we'll screen the baby for those as well. But we don't target those individual things. We're aware, we look for signs, but we don't necessarily begin formal Finnegan scoring for those things.
And maybe this is a good time to mention, we're talking about term infants or late preterm infants. For actual preterm infants, there has been described as being a lower risk to drug withdrawal and less severe or less prolonged courses, specifically with opiates. Is that right?
That's correct. And so that may be for a number of reasons. One, it may be that our tool is not designed to recognize drug withdrawal in preterm babies. So it was validated in late preterm and term babies.
And that's the Finnegan tool.
That's the Finnegan tool. So the neurologic maturity is different in a preterm baby, obviously, and so those signs may not be valid. The other reasons that there's a lower, or the other possible reasons that the incidence is lower in preterm babies is opioids in particular are lipophilic, and there is less fat accumulation in a preterm baby. Most of that happens late in the last trimester, so they don't have the same repository as a term baby does of the opioid, as well as different placental transfer mechanics, so less of it crosses the placenta earlier in gestation, as well as the fact that depending on how premature the baby is, that baby had less exposure to that drug, and so doesn't carry the same burden.
Well, that makes sense. And that's a great intro to our next big segment, which is neonatal abstinence syndrome. We're going to specifically talk about opioids. Now, we have to review opioids a little to really talk about them. But there's, as Art just said, they're small lipophilic molecules. They have a low molecular weight. They can cross the placental and blood-brain barriers. And then what they mostly do is they act through opioid receptors. Which makes sense, right? I mean, they're opioids. But these are G protein coupled receptors. There's the mu, the kappa, and the delta, and they're extensively distributed across the central nervous system and the peripheral nervous system, and GI, and some others. Now let's stop for a second, because this is right around the time when I'm listening to something like this where I gloss over it. Once I hear the word mu, my brain usually stops listening. But this should make sense for a second, because you should remember some of the withdrawal syndromes from opioids. You get tremors, irritability, excessive crying, and that's central nervous system. You get diarrhea, and then you can get significant diarrhea, and that's your GI systems. And then in addition to that, you're going to get jitteriness. And the hallmark of the hyperirritability for the neonatal abstinence syndrome is this trouble sleeping, inconsolable, high-pitched crying. When you hear this, Art, is this a type of cry you can pick out? Well, that kid's withdrawing from methadone.
Oh, so yes, it's pretty distinctive. Very, I'd almost say ear piercing.
Oh, there you go. And then remember, that's for opioids, but methadone is special, and we're going to talk about why. But one of the things now that we're talking about receptors is it exerts secondary effects by acting as an NMDA receptor antagonist, blocking the action of glutamate, the primary excitatory neurotransmitter in the central nervous system. And if you're wondering where we got this from, this was another pediatrics article. They do good work, pediatrics. This was by, I'm going to butcher this name, Prabhakar Kocherlakota in Pediatrics in 2014, issue 134, called Neonatal Abstinence Syndrome. The opioids attach to and cause these receptors, and that triggers the symptoms of neonatal abstinence syndrome. There is more things that it does, like the autonomic instability and the seizures, which are two of the major side effects, which we're going to talk about. In the brain, most important center of activity for an opioid withdrawal is the locus coeruleus of the pons. This is important because it's the principal noradrenergic nucleus of the brain and is extremely sensitive to the opioid status. So a lack of opioid causes increased production of norepinephrine, which we think is responsible for most of the signs in neonatal abstinence syndrome. So it also, as opioid withdrawals, you cause decreased serotonin expression in the dorsiraph nucleus, which causes sleep disturbance. So these kids have a hard time sleeping for that reason. And then you also get dysfunction in the autonomic and peripheral nervous system, and then, like we said, GI. Let's talk about that a little bit more. Seizures are roughly in 2 to 11% of neonates with neonatal abstinence syndrome. Obviously, it's a very serious side effect, and everything says you should treat it immediately, but that kind of goes without saying. And the exact cause of withdrawal-related seizures really isn't known. We don't know why it happens. The hypothesis is maybe the threshold for seizure activity may be decreased because you upregulate these sodium channels because of receptor instability. But they said in a number of articles, Art, that dosage of opioid really doesn't correlate with likelihood for seizure.
No, so it's a withdrawal phenomenon, and not only does the maternal dose not correlate with the risk for seizures, the maternal dose doesn't correlate with the risk of withdrawal in general.
So when you have kids who seize because of opiate withdrawal, methadone withdrawal, either way or both, well, they are both. Is it that you're going to give morphine right away, or would you use phenobarb, et cetera, to treat that? Since they say treat it right away, we should discuss just that part.
Yeah. So for the most part, a seizure caused purely by opioid withdrawal will not respond to an anti-epileptic, to an anticonvulsant. It will only respond to an opioid. So while the recommendation is to give morphine, I know that practically speaking, you're hard-pressed not to reach for the phenobarb first, but it likely would not respond to phenobarb alone.
Now, this autonomic dysregulation instability, what they say is from neonatal abstinence syndrome, you can have temperature instability, which could mean fever, but they do mention that typically you won't have fever greater than 100, 102. So don't look for this as in your 104, 105 Fahrenheit child. You have respiratory rate, heart rate instability, muscle tone, and other physiologic responses to stimuli may be impaired. These are the kids that you touch them and they jump and they cry and scream. You can also get sweating, sneezing, mottling. And these are relatively common. You see autonomic instability in just about all of these kids. Is that right, Arc?
Yes. The autonomic signs are maybe a little less prominent than the sleep disturbance and the high-pitched cry. Okay. And you know what? Can we just go back to the seizures for one second? That's one of the reasons why it's not recommended that you use naloxone in a baby who has respiratory depression in the delivery room in a mother known to have opioid use during pregnancy, because you could precipitate a sudden withdrawal. So while we use naloxone for respiratory depression, if there's an acute use of opioids in the delivery room, like during the mother's sedation or anesthesia, in that circumstance it's appropriate. But in a mom who's had long-term use, you could precipitate a seizure, which then you would have to respond to with another opioid, with morphine.
So you're saying in a mother who's opiate naive, not someone who's taking opiates regularly, if she gets something opiate-like for sedation in the delivery room,
and the baby's depressed, then naloxone would help.
But if the mother is a methadone addict or a heroin addict, and they give her an opiate to sedate her in the delivery room, you can't use naloxone in that.
You can't, because that baby has been exposed in utero, and you might precipitate a sudden withdrawal.
I think that's a great point.
And so back again to most people, particularly in the circumstance where you may not know that the mom has been on opioids during the gestation and the baby presents with a seizure, and you may give phenobarb and then you get a better history and then give morphine, you should really be prepared to handle respiratory depression that might be iatrogenic from all these anticonvulsants, including the morphine.
Okay. That was great, Art. Thank you. And now we're going to finish out the opiate section. This is just the beginning. We're talking about the drugs, their chemical structure, their pathophysiology. We're going to get into diagnosis and treatment in our next sections. We're going to quick discuss buprenorphine. Now, buprenorphine is relatively new. It came out in the 70s, in the 1960s, 1970s. It's a semi-synthetic opioid derived from the bane, a naturally occurring alkaloid of the opium poppy. It has partial mu receptor agonist action. It has some advantages over methadone, which is the primary drug it's compared to a lot, because it's used for opioid detoxification and maintenance. Now, that's two of its three FDA indications. There's opioid detoxification and opioid maintenance, which is just withdrawing and then keeping someone off of opioids. And it has less respiratory depression, less sedation, less withdrawal symptoms, lower risk of toxicity and higher doses, and at higher doses, and decreased risk of diversion. So there's a couple of studies that really compare methadone and buprenorphine, And there's actually a Cochrane review in 2013. And what it was, and let's start out by saying neither methadone nor buprenorphine are approved in pregnancy. And there's always this comparison, which we said. The Cochrane review said that there's not enough evidence to conclude that one treatment is better than another for all relevant outcomes. What they said was methadone seemed superior in terms of retaining patients in treatment. That's mothers. Retaining mothers in treatment, methadone seemed better. Buprenorphine seemed to lead to less severe neonatal abstinence syndrome. It also compared these two to slow-release morphine, but it did really mention the quality of evidence in these studies that the Cochrane review looked at was low. So there wasn't great data out there. But Ark, in your experience, have you seen less neonatal abstinence syndrome in mothers who are on buprenorphine versus methadone?
So, yeah, we see them present at different times, and we see a different severity of symptoms. And so if you look at street drugs and prescription opioids, moms who are on heroin, their babies will present with withdrawal earlier and higher scores, a little bit higher scores. Babies whose moms are on heroin, you may see withdrawal signs in the first 24 hours. Babies whose moms are on buprenorphine will present a little bit later than that, maybe around 48 hours, and their scores in the literature tend to be, the studies support this, tend to be lower than babies born to moms on methadone. Those babies present the latest of those three at anywhere from 2 to 5 days, and their scores tend to be higher. And babies born to moms on methadone tend to require a longer course of treatment than babies born to moms on buprenorphine or heroin.
Okay. Now, this would be a good point to remind our listeners that the density and affinity of mu receptors, which we talked about are some of the receptors of the opioids attached to, in neonates are as good as adults, which was a surprising fact to me. You just assume the density and the amount of them are less, but they are not. Remember the order of creation of these opioids when they first came out. There was opium, and then morphine was created, and then heroin, and then methadone. And Ark already talked about the heroin being created to treat the morphine. The morphine was created, I think, in 1808 or 6 by a German physician, and they used it primarily as sedation, and specifically in the Civil War, it was used very, very extensively. Then methadone, then buprenorphine came out. And you kind of know why. Remember that morphine is 10 times as potent as opium, heroin is 3 times as potent as morphine, and methadone is even stronger than that. And these have been around. There's even, in ancient Mesopotamia, there's discussion of opium. And then there was the two opium wars that were fought. So these things have been around causing trouble in human history for a long, long time. So, Ark, this is a good section to do a little more of our trivia.
Okay, so this is something I learned this past weekend. Do you know that no 2 guide dogs in the United States can have the same name? I learned this when I was touring blind and vision rehab services in Pittsburgh. So there's a registry of guide dog names. I don't know what happens when your guide dog dies, if somebody else gets to take the name, but of living guide dogs, they all have a different name.
The one I have is bones found at Seymour Island indicate that about 40 million years ago, penguins stood at 6 feet tall and weighed 250 pounds.
Where's Seymour Island?
I want to say in the Antarctic. I'm not sure that I'm right.
That makes sense.
All right, so now we've kind of talked about the drugs themselves, gave a little bit on their withdrawal or toxicity, defined withdrawal versus toxicity. So I think the next section we should talk about is diagnosis. And we've somewhat alluded to this a little bit. The Finnegan scoring system is the major scoring system used for opiate withdrawal. It was invented by, no surprise, Dr. Finnegan. And Dr. Balest and I decided to set off to try to figure out if it is actually validated or if it's just something we've been using forever. And it has been validated. In fact, we found a really nice article called Validation of the Finnegan Neonatal Abstinence Syndrome Tool, short form. The authors are Dr. Denise McGuire, Dr. Genevieve Klein, and Dr. Lisa Parnell, and Dr. Chun-Yi Tai. And this was in Advances in Neonatal Care, Volume 13, Number 6, 2013, which really talked about it. And Arc, as you alluded to, this was initially invented specifically for opiate withdrawal in term babies. Is that right?
That's correct. Term and near-term babies, so not validated in babies under 35 weeks.
And there is another scoring system, and right now the name is escaping me.
Lipsitz. The Lipsitz tool.
And that really isn't used as much nationwide at all. I've never seen it, but have you used it in other places, Art?
No, I've never used it. And there are other scoring systems as well. And actually, this Lipsitz tool was actually in 1998 endorsed by the American Academy of Pediatrics, but it just never took off. One paper that I saw, it was a study of practices in U.S. NICUs. Of the 75 that were polled, only 3 used this tool, the Lipsitz tool. The rest were using the Finnegan tool.
All right, and then of course there's using neonatal first urine and meconium, and really, in order to use the urine, you have to have an idea of when the mother last took the medication, because some of these medications actually end up very quickly metabolizing and you don't find them in urine. But for opiates, I want to say I'm actually forgetting the days.
It's 1 to 3 days in the urine.
1 to 3 days in the urine. And you want the very first urine the baby's going to pee out. So once they are in the delivery room, you should have a cup ready. Is that roughly right?
Yeah, the nurses try to get it as soon as possible, not with a cup, with a bag probably is a little more practical.
And then the meconium is more sensitive and more specific, but the issue with it is it does take longer.
It does, although the other benefit of meconium drug screening, or even cord tissue drug screening, is that it gives you a picture of a longer-term drug use. Probably not back to the first trimester or early second trimester, but it probably gives you a picture back to around 20 weeks. So, but like you said, Tony, the problem with that is it takes a while for those results to come back.
And just to remind our listeners, we really aren't going to talk about fetal alcohol syndrome. It's kind of out of the scope of this particular topic, but alcohol is detectable in neonatal urine for 6 to 16 hours after the last maternal ingestion. Amphetamines, benzos, cocaine metabolites are usually cleared within 1 to 3 days as well, whereas marijuana can be detectable for weeks. And then we talked about meconium, and what's it called? There's also this, from what I read, you can send hair from the infant and or the mother to detect all of the drugs taken. Have you ever done that?
No, I've never done that. But again, it's a valid way to screen, but it's a send-out test.
And now, Art, in terms of once we've screened, usually, from my experience, the mothers are pretty upfront. I've taken this, and that. Do you find that to be the case, or have you been surprised a lot?
Yeah, so, right, we always get surprised, and that's why some hospitals have a universal drug screening policy for women who come in to deliver. And that's the case at one of the hospitals where I cover. That's not the case at the bigger delivery service hospital in our system. And so the upside of that is you're less likely to miss somebody. The downside is we know that mothers avoid delivering at that hospital, the one that has universal drug screening.
Is that right?
Yeah. They'll change. That's in a more rural community. And
some of the possible predictive values from what I heard for mothers who will be substance positive is poor prenatal care or no prenatal care, obviously physical abuse from the mother being abused, lower socioeconomic status, I believe.
Yeah, and other comorbidities like HIV, hepatitis B, polydrug use. So that's why if you do get a positive screen for any drug, then it's appropriate if the HIV or hepatitis B screening hasn't already happened for that to happen. And like I said before, while we know that the Finnegan tool isn't validated for other drugs, we'll keep an eye on those babies. And even though that mom may not have tested positive when she came in, if we start seeing symptoms in a baby that are suspicious, we know that her urine drug screen and the baby's depend more on when she had her last dose of whatever the drug of abuse is. And in those circumstances, possibly meconium might be useful to you.
Now, if you have a mother who has tested or said, I've taken cocaine only, one of the drugs, not an opiate, one of the drugs we talked about that it's all toxicity, will you watch those kids longer?
So because we know that there's a higher risk of other drug use, we likely would screen the baby, send meconium if it were appropriate, if we were able to get that first meconium, as well as send urine on the baby.
Okay. And would you keep that kid longer? Or would you do a 5-day screening, or what would you do?
I think it depends what the baby is showing us. So,
Okay.
So certainly we would consider observing that baby for a minimum of 5 days, especially if that baby started showing us signs.
And according to the AAP clinical report, for our listeners, that the AAP clinical report recommends monitoring of the babies whose mother took methadone for at least 5 to 7 days. That's the range they use. Art, you want to do one more round of trivia, and then we'll get into treatment, and we'll be done.
So this is a more fun cultural piece of trivia. Do you know what the first video played on MTV was?
No.
It makes perfect sense once I tell you. Video killed the radio star.
That's true. I'm going to give you one more Mr. Rogers trivia because we are in Pittsburgh. So Mr. Rogers kept his weight his entire life at 143 pounds. And the reason was he swam every day for an hour in the morning, and he felt that people thought Mr. Rogers looked a certain way, and 143 is I love you. So he purposefully kept his weight at 143 pounds his entire life. He was vegetarian, and he swam every day for an hour, which I found remarkable. He weighed himself every day for that.
I don't know what to say to that.
All right, treatment. So let's talk about treatment of neonatal abstinence syndrome, specifically opiates. The mainstay of therapy is oral morphine. But just to be clear, there is no evidence comparing one treatment to another. So comparing oral morphine to oral methadone or oral tincture of opium, there aren't any studies comparing one versus another saying which one's better, worse, if there's less potential side effects in one. Is that right, Arc?
That's correct. There's also no evidence to say that the babies that we treat for neonatal withdrawal have any different long-term developmental outcome versus the babies who are not treated for their withdrawal.
And that's fascinating because that's good or bad, meaning we could potentially be doing some harm, theoretically, which I don't think we are, but we could, by actually treating these kids and not just letting them withdraw quicker.
I guess you just don't know, but you're treating symptoms. So the benefit would be that that baby is not in distress.
So for any of you who are interested in clinical research out there, this is an area ripe for the picking. But according to the AAP clinical report, the initial dose for morphine should be 0.04 mg per kg every 3 to 4 hours. And then you can actually go up by 0.04 mg per kg per dose to a maximum dose of 0.2 mg per kg per dose. So again, that's 0.04 mg per kg per dose every 3 to 4 hours starting. Go up by the same amount and go to a maximum dose of 0.2 mg per kg per dose. And interestingly, where I trained, we use tincture of opium. So to me, this is all remarkable that everyone uses morphine.
Well, so tincture of opium, paregoric, both of those are opium-based products, but neither of those is recommended anymore. Tincture of opium, because a tincture by definition is alcohol. Alcohol is used to extract the substance, so we don't give alcohol to babies. And paregoric is camphorated tincture of opium. So not only does it have ethanol, it has camphor and some other toxic preservatives as well that I'm not recalling now. So for those reasons, neither of those two are recommended.
Now, Ark, when you have a child, also medicines that have been used are phenobarb and oral clonidine as well. But when you have a child who's on the morphine and is really withdrawing in a bad way and needs a second medication, what would you reach for?
So we tend to reach for phenobarb, and so those will go up to around point. And so now I'm thinking in per kilo per day. We'll go up to around 0.4 milligrams per kilo per day, 0.5 milligrams per kilo per day before we'll say this baby's symptoms are continuing. We need a second drug. So we'll go phenobarb is our first choice for a second drug, and then clonidine. I have only a handful of times had to go to a third drug, and most of those babies who need a second drug, the suspicion is that it's because of polydrug use in the mom. Even if we don't find, so lots of times we'll find it in the baby's urine that there's another drug, but sometimes we don't find it, but that's a suspicion, and that's what supported in the literature, that polydrug use will make the drug withdrawal worse.
Okay. And it really discussed in the literature about sending kids home on methadone for a longer wean. Is that what you do, or do you try to wrap up the wean in the hospital?
Yeah, that's not something we do. We don't use methadone. We use morphine in the hospital.
And so you'll fit when a baby leaves the hospital, they're done with the medication.
They're done. So for a number of reasons, we don't want to send an opioid into a house where there's potential for abuse of that.
That makes total sense.
So if anybody's ever done Finnegan scoring, and most of the time it's the nurses that are doing it for us, but if you even look at that scoring system, it's really, it's a little onerous to do. It's not so hard. It's not, the concepts aren't that hard, but there are a lot of things to check off. And is he a little irritable? Is he a lot irritable? Did he sleep for this much after a feeding, that much after a feeding? And even though it's a validated tool, studies show that there is more agreement between providers soon after they have been trained in using the tool, and that rapidly drops off. So if you're using it in your hospital, I would suggest that you update the staff frequently, that you have frequent training sessions, because it will change. And so we all know that on one shift things will be different than on another shift. I mean, there is going to be provider to provider variability, but you can help eliminate that by frequent training of the staff doing it.
So for the first line of treatment for kids with neonatal abstinence syndrome is what the AAP clinical report refers to as non-pharmacologic treatment, which is basically putting them in a dark room, swaddling them tight, putting them in a quiet space. If the mother is willing to breastfeed, encouraging breastfeeding. Breastfeeding in a methadone-taking mother is safe for the child. Very little of it gets in the breast milk. I think it's 0.15 milligrams total initially, especially. And then that goes up a little bit as they continue to progress. But as long as there's no contraindications to breastfeeding, such as HIV, is that right, Art?
That's correct. And so with mother-baby care in postpartum units now, those non-pharmacologic interventions are easy to do. Babies aren't, for the most part, in big, giant nurseries where there's 50 of them screaming at the same time. So it's easy to do the non-pharm interventions like a quiet, non-stimulating environment. Interestingly, babies who are breastfed have lower Finnegan scores, but not just babies who are breastfed. You say, it's skin to skin. But babies who receive breast milk by any route, so express breast milk fed through a bottle, those babies also will have lower Finnegan scores.
And when you are counseling a mother who is taking methadone, their child's born, do you actually tell them it's better for your child to keep the room dark, keep the room quiet, wrap them up real tight because they may withdraw from methadone, and this is going to help them, especially if you breastfeed as well? Yeah,
we do. And we encourage them to breastfeed unless they are HIV positive. Being Hep C or hepatitis B positive is not a reason to discourage breastfeeding. So really that in that setting, of the comorbidities. HIV is the only reason to encourage them to not breastfeed. Or if they are not in a known treatment program, then there's concern that they're still at risk. Or if they are in a treatment program but have tested positive recently for a street drug like heroin. So recently, within 30 days of the delivery.
And then you would not recommend that they breastfeed?
Then we would not, just because it's not it's not a controlled environment, and there's concern for continued HIV exposure.
Well, I think that's a really nice way to wrap this up. I'm going to do my normal acknowledgement. So again, I'd like to thank Dr. Arcangela Balest for being with us again. We have a lot more of these newborn medicine and delivery room core competencies to go over. This was, I think, one line in the core competency. So we're going to be doing this again probably next month, and I hope you'll join me, Arc, then. For acknowledgments, again, I'd like to thank Children's Hospital of Pittsburgh for letting us use this wonderful new studio, and I want to thank our video producer, Jake. I would like to thank Dr. Megan Keene Tarchichi, who helps me out with everything, and my group, the Pediatric Hospital Medicine, Paul C. Gaffney Division of Pediatric Hospital Medicine, for continuing to support this. Thank you all for listening. I really appreciate you letting us come into your cars or workout areas or anywhere. Again, please, if you have not filled out the survey, fill out the survey. And as always, if you have suggestions or comments, feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thanks again, and we'll see you next month.